Hello and welcome to the Doc Podcast. I'm your host, Dr. Mike DeLuke, and it's my mission to help you lead a happier, healthier, and more prosperous life, both personally and professionally. So with that, I would like to welcome Dr. David Singh to the show. Welcome, Dave.
Thanks, Mike. Very kind words. I do appreciate everything you said, and it's an honor and a privilege for me to be here today.
So with that, I want to spend a little bit of time as we kind of get into the depth of this a little more, the science of it, talking about how the face grows. Talk a little bit about the etiology of transverse deficiency and how the airway can play a role in that. Comment, if you would, kind of on that duality of the environment and the genetics and where you are in that, and then some of your work in that area.
You know, this is a really fundamental concept for orthodontists worldwide, historically, what we're going to call it. The thing that we have to think about is that the way orthodontic theory was founded was on, the principles of Newtonian physics, about forces and stuff, and on Darwinian genetics in terms of how you evolved and how you can inherit stuff, which is great. However, technology moved really fast. So by the time I met Melvin Morse, I was a youngster at that point. He was almost like retiring. And it says, wow, this theory needs to be brought up to date, because even though it's a great starting point, it's not quite finished for two reasons. One is the human genome had been sequenced by 2003, which is the year I met Melvin Morse for the first time. Okay. And number two is the digital technology is that we have a better understanding of, the components, more precision, and it's in 3D. So I started looking at the functional matrix hypothesis. And the thing that struck me was that people talk about a functional matrix, but of course, what we see in life clinically is what I would call a dysfunctional matrix. People talk about form follows, function. Well, take that equation, turn it around, then, deformity follows dysfunction. Therefore, we have to retarget the dysfunction. And so let's look at the hybrid that you talked about. Is it environmental? Is it genetic? What is it? Melvin Morse, what he said is we've got the genetic thesis, we've got the epigenetic antithesis, and we have the resolving synthesis.
I love it.
When I met him, I said, "But where is the synthesis?" And he kind of tapped me on the shoulder and said, "Good luck, Big." So that is how the spatial matrix hypothesis came about, because all the fundamental stuff that Dr. Melvin Morse said are correct, but we've a bit more sophisticated. And so when you think about it, we have to take all of the tissues in the craniofacial region. We've got hard tissue, bone, it's got its own behavior. Soft tissues like muscle, got its own behavior. We've got, of course, the functional spaces, the sinuses and the upper airway. And then we've got the pearly white teeth, which are unique in their behavior because their shape and size is genetically predetermined. That can be changed. What can be changed is their position. And so what we have to have is a system that allows those 32 teeth that were, evolved over millennia to erupt into that space. And of course, the orthodontist dilemma is insufficient space. Now we have to think, how is space encoded for genetically? And this is the new bits that start coming in. And one of the concepts, the key concept, is temporospatial patterning. And so what happens is at a certain time during either embryology, during fetal growth, and even afterwards, certain genes are expressed at certain places at certain times. Every orthodontist knows, every dentist knows, incisors erupt at a certain time, the molars erupt at a certain time. It is a sequence which is guided by the genetics saying, here's a time to erupt these teeth.
Yes.
The issue, of course, is, hey, there's no space there, or there's some hindrance, okay?
Sure. Yep.
And so this is where I came with the idea of a spatial matrix to say, if we unravel that dysfunctional matrix, we end up with a spatial matrix. And one of the beauties of that, from the human point of view, is symmetry. So we are genetically encoded to be symmetrical on the outside of the body and kind of asymmetric on the inside. But look at the teeth. They are genetically supposed to be symmetric.
Right.
And so we already have a starting point. We know that axis formation occurs very early on during embryonic development. The midline, right, left, front, back, top and bottom, all of that is genetically encoded.
Yep.
And you're going to keep that pattern for the rest of your life. and the teeth are supposed to erupt into that blueprint.
Yep.
So what happens is that, the teeth are trying to erupt. That's a developmental process.
Mm-hmm.
But at the same time, when the genes are interacting with the environment and you get a slightly different solution, also known as a malocclusion.
Mm-hmm.
So when I read, Engel's, and I was taught Engel's classification, I thought this is brilliant, except that in real life, there was a bit of a mismatch. It doesn't quite give me where I want to be.
Agreed.
So I was, I don't know if it's bold enough, but what I did, I said, let's update this definition of a malocclusion. So my definition now is actually, it was briefly published in the British Dental Journal. A malocclusion is a solution for a complex adaptive system to remain in homeostasis. Homeostasis is the antithesis of relapse. If you're in homeostasis and balance, in equilibrium, you're not going to get relapse.
Yep.
And so the malocclusion is saying, this is the best I can give you in the conditions that I'm working in.
Mm-hmm.
Okay. And so what we know is, if we do a surgical case and an orthodontic case, we do decompensation.
Yep.
That is stage one. That is early treatment. If you decompensate the system and then allow the natural body plan to come into place, that is the kind of theoretical basis, if you will, of the spatial matrix hypothesis.
That's really and clearly explained.
Right, absolutely. And we're at a bit of a disadvantage because we're already downstream.
Yes, yes.
The last part of the equation is the teeth. And it's a bit like building a house. You lay a foundation, put up some walls, put up a roof, and the last thing you do is the interior design.
Yep.
And so that is where the teeth can be positioned into the space that's available. The other thing that I noticed, and this is how the research that people have done in the past starts to accumulate and eventually takes to a new level, is that when we do a diagnostic workup, we need to be a bit more broad.
Mm-hmm.
And this is where the new technology comes in, specifically things like a 3D cone beam analysis.
Mm-hmm.
So when I do my diagnostic workup, I'm going to go from the top down, just following that developmental pathway, which means I got to start at the cranial base.
Mm-hmm.
And I have a little catchphrase, which is the cranial base sets the pace for the rest of the face.
I love it. Love it. Cranial base sets the pace for the rest of the face. I love that. I might borrow that with the residents if that's okay.
So the strange thing here is that we have a very diverse population worldwide in the US and wherever you go. And so not one size fits all. Mm-hmm. And so I was thinking to myself, why is it that we have these different kind of phenotypes?
Right.
And if you think about the cranial base, you've got an anterior part and a posterior part. The maxilla midface essentially is attached to the front part, the anterior part. Mm-hmm. And so the cranial base gets there first. And so the maxilla is downstream from that. Mm-hmm. So if you have a long cranial base, the maxilla moves forwards with it because it's actually the sutural system allows the midface to move forwards with the cranial base. Yep. If you've got a short anterior cranial base, the maxilla doesn't move as far forwards and you have a tendency for a class 3 phenotype. Mm-hmm. Now think about, the angulation, the cranial base angle, the saddle angle. Mm-hmm. If it's acute, the mandible is going to articulate with the posterior cranial base. So if you've got an acute angle, the mandible moves forwards, more likely to be a class 3. Mm-hmm. If you've got an obtuse cranial base or a short cranial base at the back, the mandible is set further back, more likely to be a class 2 clinically.
Yep.
What my idea there was that class 2s are developmental and postural compensation. They don't exist genetically.
Interesting.
What you have is either class 1 or a class 3, and both of those, the teeth are going to be in a class 1 cusp-fossa relationship. So you go to Asia, you go to Africa, generally speaking, those populations have a short anterior cranial base phenotype. Mm-hmm. You go to Europe, the Middle East, South Asia, people have got a long cranial base phenotype. And the easy one to look at is the bridge of the nose. If you've got a well-developed bridge of the nose here, the chances are you have a long cranial base. And if it's more obtuse, the chances are you have a short cranial base phenotype. And then you can say, okay, where do I need to put this maxilla? Where do I need to put the mandible to allow all of those things to stay in stability and homeostasis? Because the cusp-fossa relationship is all about stability.
Yep, completely agree. I love too the way you think of things differently and getting at that etiological perspective. How do you describe, how do you explain the role that breathing has on the craniofacial growth and development?
Well, that is absolutely critical. So remember this, that babies are obligate nasal breathers. They just want to breathe through their nose.
Mhm.
And so the way humans are mammals, and so the whole thing about mammals is it's, suckling, breastfeeding, nursing at birth. And so this kid, this baby, is able to breathe through the nose and swallow through the mouth, okay, whilst they're breastfeeding. That is what we are set up to do. What have we done? We're saying, let's get rid of that. I'm going to replace this with a plastic appliance called, a plastic feeder, bottle feeder, pacifier, whatever. And so what happens is the system now has to adapt and accommodate to this new environmental stress or interaction. And so one of the things the tongue does is saying, well, I don't need to go onto the palate. I'll sit on the floor of the mouth.
Okay. Yep.
Now, if you sit in the floor of the mouth, the chances are it'll fall back and obstruct, behind the mandible. Now you've got an air issue there. Or if the palate is not broad and flat because the tongue is not molding it.
Yep.
Now you change mode into an oral breather, mouth breather. You start getting hypertrophy of the tonsils. It makes a bad situation worse.
Yep.
And so what's happened is our child rearing practices from the get-go have changed fundamentally. What we feed our kids, how we feed our kids, when we feed our kids. And so, wow, suddenly the genes were expecting this type of signaling, and you take that away and replace it with something else.
Yep.
And now you get developmental compensation and partial compensation. And then you say, okay, now unroll that for me,
Yep.
So if you think about what kids are eating at a very young age, that's a bit like food-like products, these processed foods.
Yes. Yep.
Which look like milk, but they're actually formula. Okay. And the consistency is that they're pre-digested, if you will. They've been all mashed up. And so, the idea of taking some veggies, mashing them up and giving to the kid. Well, you go to some developing country, and I've seen it myself, where the 2-year-old has got a carrot in the hand.
We'd be running like they're going to choke, right?
Exactly. What we have are primitive reflexes, survival reflexes. All of these are going to be slightly modified as you come into a modern or a more kind of industrialized society.
Yep.
So, for example, let's take the baby now who had been breastfeeding exclusively since birth, okay? Just like our Homo sapiens 30,000, 40,000 years ago, all of those kids were exclusively breastfed or they didn't survive. Okay, that was the choice, okay? So now we say, okay, so this little baby now is now 3, 4, 6 months old, and it needs more nutrition. One of the primitive reflexes that these kids have is they use their hand to prime the other breast whilst they're feeding from the first one.
Okay.
And then at some point they're going to switch over, and then they're going to feed from the second breast.
Okay.
Now, if that a reflex is kind of suppressed, if you will, instead of priming the breast with the fingers, they start to do other things like, sucking their thumb, picking their nose, playing with their ear, playing with their hair. It's a reflex that has been misdirected.
Interesting.
Now you have a child who's walking into the dental theater, into the orthodontic clinic with a thumb in the mouth.
Yep.
And guess what? They get non-nutritive value from that. The endorphin release, oxytocin relief, it makes you feel good. Suckling is reinforced, so this kid will survive. And now we're saying take the thumb away. The kid's saying, no, I want to survive. It's a very basic instinct. Now, this happened to me personally. And so my son, I saw him thumb sucking. I thought, wow, look at this. This is totally amazing. So how do I get rid of this thumb sucking? So when you take a child away from the parent, they get separation anxiety. The closer they are, you don't do anything. You just have to be in the vicinity of the parents because it's a survival instinct. So what I thought was, okay, if I go closer to him, see what happens. And then I said, what happens if I hug him? And whilst I was hugging him, I just gently moved the thumb away from the mouth. And I did that over a period of time to the point where when he wants a thumb suck, he would come over to me and get a hug
Okay.
instead.
Yeah. Wow.
This is parental behavior. We all have it, and we
Yeah.
all write it because we're not, sometimes looking or aware.
Yep.
I've seen so many kids like you have, from babies right through to teenagers. I'm looking at you pick this up kind of clinically in terms of how this kid is behaving.
Hmm.
It's intuitive, but thinking, how do I take this information and make it into a better orthodontic or dental procedure?
Yeah, and that's the course which I had briefly, we were just kind of talking, was saying one of the things I'm developing on my C platform is certain courses, and the next one that I'm actually writing right now, is literally on breaking the digit
Mhm.
habits in younger patients.
Absolutely. And then we were thinking about this kids start to get older. They're going to now erupt, primary teeth, primary dentition. Okay.
Hmm.
And what are we feeding these kids? It's going to be the burger, it's going to be the soda, it's going to be the
Hmm.
fries, it's going to be all of this processed food.
Yep.
And again, I've got no, kind of agenda here, but just observation
Hmm.
is that this type of food differs in two major ways. Number one is that there's a whole bunch of additives added, either, sweeteners or
Hmm.
flavoring or stabilizers or colorants or whatever.
Hmm.
Number two is the consistency of this food. It's pre-digested food.
Yeah.
It's soft food.
Yeah.
So you're thinking, what's the big deal? This food tastes great.
Right. Very
And
palatable. Very palatable. Right.
exactly. And it's stable. You don't
Yeah.
have to, it's got a very long shelf life.
Yep.
And all of these ingredients have been tested for biocompatibility,
Hmm.
and we know that they are non-toxic. So what's the big deal? The
Hmm.
big deal is this, is that they have been tested in context. And what I mean by that is microbiome.
Hmm.
So what happens is you eat this processed piece of food, whatever it happens to be, pick your favorite one. It goes into your gut, into
Hmm.
the child's gut, and now those additives and stuff are actually exposed for the first time.
Hmm.
They're not toxic to the human, but what they do is they change the microbiome inside of the gut of the child.
Hmm.
Next thing you know is this kid's got inflammatory conditions, leaky gut, irritable bowel, or they've got, stuff like eczema,
Hmm.
asthma.
Hmm.
They've got some stuff going on, which you're thinking, where is this coming from?
Yep.
Because the gut bacteria change in terms of the good ones, the bad ones, and the ones that make no difference.
Yep.
And if you displace the good ones, now you set up a chronic situation for the long term.
Hmm.
So the idea here is, okay, well, how about, especially early on, give these kids a pretty decent, I would say, organic raw diet to say this is the basis of the diet. You can add, all the other stuff you want to do as a bonus or a prize or luxury, whatever, at some
Hmm.
point.
Hmm.
But the basic staple diet should be pretty close to what we nature intended in that respect.
Hmm.
The number two is the consistency of this food, which is
Hmm.
critically important.
Hmm.
And by the way, for the processed diet, what they found is the kids who are on that type of soda, cola type of diet,
Hmm.
their sleep routine is like out of whack.
Believe it. Hmm.
You can tell from the kids who have that type of diet that their lifestyle mirrors it, and their sleep mirrors it, and then what happens during the day, it goes from bad to worse.
Yep.
So what happens, in these kids is that they don't do well at school, they have behavioral issues, and sometimes it's the fact that they're not eating well, not sleeping well.
Hmm.
And, that's a whole big topic right there. But let me
Hmm.
just finish what I was going to say about the diet here in terms of consistency.
Hmm.
We need a hard diet.
Hmm.
So here's what happened. So I went to the World Sleep Society, I think last year or year before, and there was a presentation on sleep bruxism.
Okay.
And the test that they had done was to feed these rats this very hard pellet to make sure they got a lot of tooth wear.
Hmm.
And they were saying, this is our model for bruxism. And I kind of put my hand up and said, it's a great model, and I love the findings, but I don't think you're testing bruxism. What you're testing is the effect of the hard diet,
Hmm.
because bruxism happens when there's nothing in the mouth. And the hard diet is when you crunch down on something.
Hmm.
And so that was the point of, well, blah, blah, blah. But the point is, what were the findings? With the hard diet, you were getting increased blood supply to the brain. I thought, oh my gosh, Bruxism is in fact some form of survival mechanism.
Hmm.
So when you bite down hard, you actually divert blood to the brain and it's going to keep you alive, you know? So the long story behind that, but just think about a predator who's hunting for prey. It takes them, they rush for this prey 30, 40, 50 yards. By the time they get there, they're exhausted. They catch the prey, but now they've got the mouth closed.
Yep.
So now they've got to breathe through their nose.
Yep.
And the clench that they do allows the blood to go to the brain, perfuse the brain through nasal breathing, and they are going to survive because they caught the prey. These are the kind of ideas to think about how did that translate into human behavior, into human diet. And this is why Homo sapiens, our big deal is we've got big brains. And the way you feed those big brains with a great blood supply, full of oxygen, and some nutrients that go with it. Okay. So there's a very strong relationship between tooth development and brain development, which is just like, why did we kind of miss this part of the story? It's all there.
Yeah. Yeah.
It just doesn't make the headlines, you know?
No, right.
All there.
Yeah. Again, thank you for your clear explanation of that. Really, the malocclusion is a relatively evolutionarily, it's a very new concept. And one of the things I'm really big on is the importance of nasal breathing in children. And I'd love to hear your thoughts on that as well. But talk to me a little about how, so when you see a patient come in, child, pre-adolescent, what are you looking at? Kind of where does your diagnostic process begin, and what are the main things you're looking at? Talk to me a little bit about how you approach the diagnostic process.
Absolutely. I mean, this is so critically important, Mike. And the thing is that we are all busy and we have a line of patients, and it's about time and quality of time. So when I say this is ideally what I want to do, and I do this if you get the chance, is number one is when that patient walks in, you don't want to see him sitting on the dental chair. You want to see him standing up. And what I say to the child is, I want you to stand up and look out the window, just look straight ahead. Okay. If you do that and look at the child from the front, what I'm looking for is the head actually straight on the shoulders, or is it tilted or rotated? And number two is I'm looking at the shoulders themselves. Are the shoulders in the parallel straight line horizontal, or is one shoulder higher than the other? Okay. I will say that in a large number of cases, there will be, a tilt of the shoulders and some kind of rotation of the head. This is postural compensation. Because this child knows I'm a predator, so I've got to have horizontal gaze, but at the same time, I've got to keep my airway open. And so what happens is you get a bit of a forward head posture. Yep. And so you start looking at immediately what is the compensation this child is walking in with, developmental compensation and postural, that I have to untangle for those teeth to be sitting in equilibrium by the time I'm done. And so this is not rocket science. We can do it very quickly. We love to work with, in other cases, there may be scoliosis, there may be some stuff going on. And if that's the case, I will work with a chiropractor or a physical therapist to say, I want to go from general to specific, align the body, align the jaws, align the teeth in that sequence. That is, you go from general to specific. And so what we want to do here is to say, how is this child, behaving as they come in? Then we can say, okay, now the two things I'm looking for classically, and depending on the case, of course, is I want a 3D cone beam. I'll go from the top down to find out where the structures are. But I also want the functional read to say, how is this kid behaving? And the behavior I'm most interested in is airway, breathing, and sleep. And so if there is a shadow of a doubt, you're probably going to end up with some kind of sleep study, or at least you do a PSQ, pediatric sleep questionnaire, to find out how is this kid sleeping, what's the quality of the sleep, are they getting sufficient sleep, and then put two and two together. They're sleeping well, they've got no issues, great, straight orthodontic case, wonderful. But don't make the assumption that this kid is doing great, because they might not be. We have seen children of the age of 15, 16, 17 who are still bedwetting. Now, how does that come out of an orthodontic consult? You know, it's that you have to make friends, you have to engage the parents, they have to feel comfortable to say, I can tell you about this kid generally, and I'd love for you to fix their occlusion specifically. You know, that is a very broad approach. Do we have the luxury to do that in real life? I don't know. But to me, that is you know, the holy grail. That's the ideal that should we be aiming for in terms of how do we start a diagnostic process.
And that's looking at it from the outside in, how this patient looks from the front, looking at them, head posture,
Yeah.
and then starting to go from the outside, looking at their eyes, right? And venous pooling, allergic shyness, there are signs of atopy there, allergic, transverse crease, all of these different things in the face that tell such a story.
The thing is about the malocclusion is, and I completely agree with you, and I think that should be our prime target. However, you buy one, you get one free. What I mean by that is that, you've got a malocclusion, but the unwritten or unassumed maybe a TMD problem or an airway issue or something else going on. So I always think that the diagnosis has to broken up into 2 or 3 different parts. One is, we'll say, kind of craniofacial to say, what kind of case am I dealing with here from a craniofacial point of view? Number 2, what is the TMJ doing? Where's the positioning of these jaws? And then number 3 is, what are the teeth doing now? And if you do it that way, you'll get a good read of how is this patient's airway behaving. Do they have a nasal airway? Do they have tonsils? Do they have a low tongue posture? Are they a mouth breather? Do they have an everted lower lip? So on and so forth, which we see every day. We recognize every day.
Yep.
And we drive right past, right?
Yes. Yes. Yeah.
So slow it down and say, okay, I want to make sure that when I finish this, the tongue has a house that it can occupy. And that house is not the floor of the mouth. It's the palate. It's the roof of the mouth. If the tongue is sitting in the roof of the mouth, those lips will come together very gently. The teeth will be in occlusion. And guess what? The guy's going to be breathing through the nose.
Yep.
That's pure physics. It's just pure physics. Okay.
Right.
And so that is our end point. If they can sit or stand with the teeth together gently, lips together gently, and breathe through the nose, game, set, and match. It's a done deal. Now, of course, you've got aging that comes into that later on downstream. This is where you need to say, this is the ideal finishing point for today. Yep. However, aging is going to, kick in over a period of time. So you've got to be aware of that. And so seeing patients over a long period of time is a great thing to do and allow them to age gracefully. Okay, they're going to lose some bone mass, muscle tone. All of this is expected. However, we can monitor that as this child goes through childhood, adolescence, young adults, so on and so forth. So diagnostics to me is the critical part of this thing. I want to know, is this a class 1, class 2, class 3 case? I want to know what the TMJ health is or the status is. I want to know, do they have an obvious or a hidden airway, breathing, and sleep issue? And if I suspect that, we can go and investigate further.
How do you find that, or how were you able to get successful at coordinating treatment with your dental and medical colleagues, myofunctional therapists, et cetera?
What's the phrase? Make friends and influence people, So have a lunch and learn. Because exchange information, because what I love to do is go to the orthodontic conference, but also to the sleep conferences.
Okay.
And then what we want to do is get our orthodontic people into the sleep conferences and present their findings and get the conversation going. Because don't assume that our physician guys know what's going on and vice versa, because they don't.
Yep. And
so we need to start open the conversation and saying, I'm local, I'm doing this, blah, 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 and just get that conversation going. So you need to build a professional network around you. It's not huge, 3 or 4 people. Pick a physician that you can work with, that you get on well with, and you have some similar, things in common, values and stuff. It could be an ENT, it could be a sleep physician, internal medicine. I really don't mind. It has to be a physician, because when you need a sleep study done and to be read and interpreted and a diagnosis made, they're going to make the diagnosis for you. You've got to have that in place. And it's easier now than it's been before, but that is, a key part of this team. Number 2, again, not in any specific order here, you've got maybe a chiropractor or a physical therapist or someone of that nature. It could be an osteopath if you're in Europe, for example, because we go from general to specific. And so when you think about 32 teeth, you've got 32 vertebrae. Maybe it's just a coincidence. Okay. But when you start thinking about how this mandible is going to behave, the axis of rotation of the mandible is at C1, C2.
Mhm.
And if C1, C2 are not well aligned, the mandible will compensate for that, saying this is the best I can give you because my neck is not in the right place.
Mhm.
Now, we've seen this many times. We haven't published on it, but we've done, a number of studies on this, clinical studies, to say that when the cervical alignment is good,
Mhm.
as in ideal, the airway opens up and the mandible comes forward, saying, "This is where I would like to be to allow you to breathe."
Mhm.
Now you've got a mismatch between the mandible and the maxilla.
Yep.
Well, guess what? There's a thing called palatal expansion for
Yep.
that reason,
Yep.
where you can get those guys to start to re-coordinate and get those teeth, in a beautiful cusp-post relationship. So number two, I like to have a chiropractor there. You don't need it in all cases, but I like to have it in some cases in case there is a structural postural compensation that's going on,
Mhm.
which will compromise my outcome, my stability,
Mhm.
because the body can't keep it there. As you mentioned, number three, it would be a oral myofunctional therapist.
Mhm.
Critical, either from prevention point of view, from a therapeutic point of view, or
Mhm.
from the long-term stability point of view. And it could be all three.
Mhm.
So here's a child who has some kind of habit, tongue thrust, whatever it happens to be.
Mhm.
If you got a anterior open bite, the first thing I'm going to do is saying, how about training the tongue? It's muscle. We can
Mhm.
train this muscle.
Yep.
And we've got people who know how to train this muscle. They're
Yep.
called myofunctional therapists. So the first thing I'm going to do is get that tongue trained. We may or may not have to do a release of the tongue to say it's actually able to reach the roof of the mouth or not.
Mhm.
And so building those people at the beginning is a preventive type of approach. Therapeutically, it makes, especially if you've got a patient who's got some kind of airway or breathing or sleep issue,
Mhm.
we know that oral myofascial therapy can help with that kind of condition as well.
Mhm.
And in the long term, when you got aging, you get vertical drift of the face,
Mhm.
which kind of tends to retrude the mandible, which tends to impede the airway. But with oral myofascial therapy, you can actually decrease that rate of aging. And I'm talking very generally now,
Mhm.
okay?
Yep.
Particularly with people who are, very compliant, because a lot of people doing these tongue exercises, it's not their deal,
Mhm.
okay? But so those are the three or four people you're going to surround yourself with. And you may add one or two other people, for example, the nutritionist, to
Mhm.
say that what is this child eating? What are the dietary habits? And that will actually overlap with their sleep. And so one of the things that with children is that they need to be given a pretty decent timetable schedule to saying this is bedtime
Mhm.
and specific rules that there's no blue screen, there's no cell phone, there's no computer, there's no laptop in the bedroom.
Mhm. Yep.
Because that blue light, as you know, is going to suppress the melatonin
Mhm.
and it's going to make them not sleepy.
Yep.
So we have to think about how we behave. So, for example, you go to sleep, you set your alarm for the next morning, okay? The alarm goes off. What do? You press snooze,
Yep.
okay? The body does it the other way around. So we have the circadian rhythm. Kids have it extremely well developed, okay? And what happens is when that darkness gets a little bit darker, your melatonin starts to be released and you start to feel sleepy. But what do? We press the snooze button and start
Mhm.
watching TV or
Mhm.
gaming or whatever instead.
Device. Yep.
And that is where you got to say, no, blue screen's got to go now.
Yep.
And this is a bedtime. And this is build a strong, comfortable routine to say, time for bed.
Yep.
Simple things like that can make a difference.
Why do you think there's this divide between academia and clinical practice?
Well, it'll be like that forever. And
Mm.
so the reason is that they have different goals.
Okay.
Academia, by definition, has a different goal. It is to pursue the research, the development, the literature, all that kind of stuff needs to be
Mhm.
done for idealistic reasons.
Mhm.
Okay. Now, so what happens is the research is going to produce information and data and knowledge.
Mhm.
Now we've got the clinician different point of view is I'm going to take that information, that knowledge that you just given me, I'm going to apply it to my clinical scenario. And what happens over a period of time, you keep doing that over and over again, you get clinical experience and wisdom. So you know what works and what doesn't work. And by the time you figured it out, it's time to retire already. Okay.
Yeah.
And so, this is what happens is that the research keeps going on, the data is transferred, the experience is then, and this is where artificial intelligence is going to maybe be the connector here to say, we take that clinical wisdom, that clinical experience, big data, okay, huge number of cases, and say, okay, AI, this is the 8-year-old child, thumbsucker with a class 2. Do I need to do a Herbst here, partial expander here? Do I need to extract a blah, blah, blah? Right. They will then come out and say, based on N thousand cases treated by X number of,
right.
Here's what I would do. The question is, do you believe that or not?
Right.
Okay.
Right.
So data going in, the quality of data going in will determine the quality of the result coming out.
Yep.
So the academics are pushing all these boundaries. We now know specifically the genes, the cytokines, all of the molecular detail that we never even thought about, 100 years ago. We have all of that stuff. How do you use that now to say, here's my, 11-year-old child who's just going to start that growth spurt and it's going to mess up everything,
Right.
So there is going to be this, it's a game, it's an exchange. The other thing and again, my opinion is that the research sometimes follows the clinical experience and sometimes it's the other way around, and it could go in either direction. Okay. So what happens at the end of the day is, where are you going to say, where are you going to settle, which side are you going to take? So the academics will always say, here is what the data shows us. And all of that data is retrospective. It's all based on the studies that were done N years ago by all these different people. Okay. And the data says this, and then it's the quality of the research saying, based on the quality of the research, here are the recommendations. Okay. Those recommendations may or may not synchronize with your clinical goals.
Agree.
And that is where the dilemma comes in.
Yes.
And you have an open, frank, dispassionate discussion to say, what is best for this particular patient, despite all the stuff you just told me.
Yep.
Yeah. So, I've seen it many, many times where you think, the AHI says this on the sleep study, but actually I'm going to do this instead.
Yeah. Right.
Based on clinical judgment that you have based on your experience.
Yes.
So it's not an easy question to answer. We can address it, we can talk about it, but there's no simple answer.
Yeah.
And how do you teach that to the residents? Is that, how do you teach this? They will pick it up. It will rub off on them the more time they spend with mentors like yourself and other people who have been doing this for a while.
So, do you think that's why a lot of our colleagues don't think the way you and I think, in line with what you've been describing?
I think the other factor to throw in there, Mike, is I'll call it commercialization, where people have a brand new product and suddenly it's the best thing since sliced bread, And then the academic is saying there's no evidence to support that. And again, I've got no agenda here whatsoever, but take a clear aligner as an example. They flooded the market and there was very little research at that time to say this would actually do anything. Okay. Despite that, they're a significant part of the orthodontic, market. And so you have to weigh all these different kind of approaches to say they have got a commercial interest. It's a for-profit corporation, and good for you. That's fine. That's how the world works.
Right.
However, the clinician's got to say, do I now buy the commercial product with all its advertising and marketing, or do I say, listen to the academic who's saying there's no studies to support that, and so on and so forth. So it's a moving target. And again, there's no simple solution there. But I think for the next generation of orthodontics, we have to think about integrating orthodontics into human health.
Love it.
Absolutely. Because if you go back and look at how critical the teeth are for survival, now what we've done is change our environment to allow us to survive even if we have no teeth.
Right. Right.
As a mammal, you can't do that.
Right.
I'll give you, there's lots of classic examples. A whole big study done in England actually on sheep. Now, sheep get periodontitis in the lower jaw and the incisors fall out.
Okay.
The sheep can't feed and it dies.
Hmm.
The farmers, it's called broken mouth. They call it broken mouth. So the farmers, as soon as they see that, oh my gosh, I've got to check my whole of my herd to make sure there's no, pathogen going around because these animals cannot feed. We have changed our diet, changed our food stuff, changed our lifestyle to find out we can survive even without teeth. But teeth still genetically, developmentally, functionally are critical for human health and the quality of human life. Now I'm talking 32 teeth now. Okay, so why is it that we can get away with reducing the number of teeth? That's because we've changed our lifestyle.
Yep.
Now, we didn't publish this study. The data was there. We just didn't get around to it. But what we were doing are looking at high schoolers, footballers, who had certain teeth extracted. Either they were premolar teeth or wisdom teeth.
Okay.
And for whatever reason, dental reason or for whatever reason it was, we didn't publish a study, but what we found was that it looked as if the kids who had the teeth extracted were more likely to get concussions.
Really?
Yes.
What did you find what that was related to? Any theories on it?
I think so. So let's just take a step back. So the study actually started at the role of mouth guards to prevent concussion.
Sure. Yep.
And we published that study,
Yep.
published in Dental Traumatology. And it showed that if you wear a mouth guard, you do decrease the rate of discussion in these kids. Absolutely. But we didn't finish it in terms of going and looking at the kids who had the extractions later. So the idea here is that, if you have, again, it comes back to that bruxing clenching idea. What they do is they provide a big surface area. And so every time you eat this very hard diet, you're actually not traumatizing, giving micro trauma to the brain. You're actually protecting the brain with these big teeth. So think about concussion. Now you've taken away the surface area and the force is transmitted through the teeth, through the TMJ to the temporal lobe. You get atypical temporal lobe activation, also known as you're out for 10,
Yep.
So this is part of it. Now, we have bits of other studies that kind of point towards that. We had a group of patients with MS, multiple sclerosis, and a control sample. Okay. And we allowed in this study to allow them to chew and clench and grind and brux. And what we found is that the control group had the regular amount of movement of the temporal bones, but the group with the MS, they had hypermobility of the temporal bones. In other words, they were compressing and squeezing the brain when they were grinding and clenching. Some brilliant stuff came out of that study. It was done at University of California, San Diego, I believe. And the thing that came out was the sutural width. I thought that was a clencher for me because the sutural width in the normal control subjects was approximately 250 microns, which is 1/4 of a millimeter. And in the MS group, it was like 3 times as wide. But the reason why it's interesting is because orthodontists, when they turn the palatal expander screw, they turn it typically 1/4 of a millimeter.
Yeah.
And where did that number come from? We found it by trial and error because the periodontal width is about 250 microns. So this time now goes into palatal expansion, which is, again, a very interesting topic. I think it's a slightly misunderstood or it's a bit of a misnomer, but the study was done in these deciduous children and young children, and they want to see when they turn the screw, how wide the mid-palatal suture got and how much transverse expansion you actually got. So they kept on measuring over a period of time. They published a study, and the finding was that even though the transverse width of the maxilla increased, the suture didn't increase in width, and therefore there must be some other mechanism involved. I read that study maybe 10 years after it was published. I said to myself, my gosh, they have missed the idea of sutural homeostasis, which is encoded by genes. And so what happens when you expand the maxilla, you stretch the suture, it gets wider, but the body's response is to fill it back in with brand new bone. So every time you measure it, it comes back to the same width approximately, and at the same time, you've actually got more bone deposition. And so sutural homeostasis is one of those newer concepts that we drive right past it because we call it a periodontal ligament. But in fact, it's a periodontal suture. And the hallmark of sutures is that they are packed full of stem cells. And so when these stem cells, they're actually niches for stem cells. These studies have just come out, in the last 5-10 years. That's what the sutures are there for. So if you get trauma, if you get stretching of the suture, they will deposit bone. And now it starts to make sense. You think, oh, okay, now what I'm trying to do with my partial expander is not widen the palate, but actually stretch the suture and leverage that to make bone on my behalf.
Yep.
And now I can put the teeth into a nice big bony base and we should be good to go. So it's funny how all these, ideas that we had in the past are slowly starting to come together.
Isn't it fascinating? And I love that you said orthodontics has to have a greater interaction and be looked at as having a bigger role with human health. Kind of give you the last word. What would you say is the biggest take home message that can kind of get us to that next step as a profession where we start to view orthodontics in the greater, broader perspective of human health?
Well, I think that number one, this is not rocket science. This is stuff that we actually know. We were taught to maybe a lesser or greater extent.
Yep.
The question is, how do I then take that and use it in my clinical office
and apply it?
Yeah. So it's kind of, from a very simplistic point of view, treat the patient, treat the whole patient. What we were taught was, for cavities, don't treat the whole, treat the patient as a whole.
Right.
There's a whole patient walking in. I am not treating your teeth today. I'm treating you as a patient who has an orthodontic issue that needs to be resolved for the overall, well-being of this individual. That's what it's about. And so start with simple things that make sense to you. Is this patient a nasal breather, a mouth breather? They got a tongue thrust. If they got crowding, crowding is developmental compensation. They just compensated. So think about saying, I need to decompensate before I put the interior design into place.
Right.
Look at those 4 tissues. Think what the bones are doing. What is this muscle doing?
Yep.
What are the functional spaces, the airway doing? And then I know where to put my teeth.
Yep.
It's that sequence.
Yep.
We love to go in and say, get those, brackets wise, whatever in place.
Yes.
I get it.
Yeah.
But hold on a second. Just take a deep breath, literally.
Yes.
Say,
Right.
Put it into context,
Yeah. No, that is so true. I love it. I can't thank you enough for taking the time. I mean, how quickly that went by. I just love listening to you, and I love how you can take such complicated concepts and distill them down. So for people who are looking to learn more about you, what you do, and some of what we talked about today, is there anywhere you could direct them for that?
Yeah, there's a couple of books I've written. One of them was published very recently. It covers a lot of the topics that we've discussed today.
Okay.
And it's got a long name, Pneumopedics and Craniofacial Epigenetics, PACE. Okay. So you can look that up, and a lot of the topics are actually covered in that one.
Okay, great. And I'll put a link in the show notes to that too, for anybody who wants that. And is there any way to reach you directly if they have any questions or follow-up questions on that?
Absolutely. I can give you my email, which is drsingh, SINGH, at drdavesingh.com.
Okay, awesome.
Thank you so much, Mike. I appreciate it.
It's been an absolute pleasure. I so enjoyed having you on. Thank you so much for your time and expertise and all you've done for the profession over the years and continue to do.
Thank you, Mike. It's been a real pleasure for me. I really appreciate it. Thank you so much.
Yeah, no, you're welcome. Thanks so much for being on. It was my honor.
Okay, thank you.
All right, take care.
Bye.
Bye.